minutes to pass, so let us begin. So, good evening, everyone. A very warm welcome to members of BSMS faculty, including the Dean, Professor Malcolm Reed, external academics and audience, external medical students, and BSMS students, as well as several secondary school prospective medics. It's wonderful to see you all here tonight for a rather special event. Just to give you an outline for how our webinar this evening is going to work, Dr. Igbineweka is going to be going through his talk, and then we will have a note of thanks from our Dean, Professor Malcolm Reed. This will be followed by an interactive Q&A session. Whilst we are scheduled to end at 7:30, if there are any other questions which Dr. Igbineweka needs to answer, he is very kindly offered to remain with us until 8 p.m. So there will be plenty of time for questions. So please do post them in the Q&A section of the webinar. After the Q&A session, we will also have an announcement from two Anthony Nolan reps, and this will be delivered by Ellie Brooks and Valentino Rossi. So our guest speaker this evening is truly someone special. Indeed, his CV is the length of my arm plus more. Dr. Igbineweka is presently on a joint PhD fellowship at Imperial College London and the University of Oxford's Weatherall Institute of Molecular Medicine and Haematology. As you just heard, whilst also continuing to practice as a haematology specialist ST5 registrar at King's College Hospital NHS Trust. Dr. Igbineweka obtained his medical degree from King's College London in 2011. In addition to this, Brighton can say with great pride that Dr. Igbineweka spent 4 years in various specialist roles at BSUH, including his academic foundation year 2 and academic clinical fellowship programs, whilst completing his training, during which time he completed his master's degree in medical research at BSMS in 2018. Dr. Igbineweka held the prestigious Fulbright Scholarship from 2016 to 17, a grant awarded to international students to study in the USA on specific research projects. During his time at the National Institutes of Health, the NIH, in the USA, Dr. Igbineweka carried out a retrospective and prospective study identifying VQ scanning as more sensitive in detecting pulmonary emboli in sickle cell disease compared to CTPA imaging. He also acquired more molecular-based techniques at the laboratory of Professor Sweelathane at the NIH. Whilst leading the fields of academic and clinical hematology, Dr. Igbineweka is also a passionate educator. My fellow second years may recall with fond nostalgia that Dr. Igbineweka delivered a thought-provoking epilogue during Dr. Tim Chevassut's Sickle Cell Symposium. It is no surprise then that as a newly qualified Foundation Year 1 doctor, Dr. Igbineweka initiated and led 2 national haematology courses titled Basics in Haematology for medical students and Haematology core medical trainees. These successful courses have been assimilated by the British Society of Haematology as part of their education portfolio, to which Dr. Igbineweka was formerly on the BSH Education Subcommittee. I think one of the most inspiring aspects of Dr. Igbineweka's career is his diverse range of experiences in both academia and clinical medicine. His drive and passion to understand the scientific basis of disease is fueled by his motivation to provide the best possible care for all of his patients. This is certainly, and I'm sure my fellow medical students will agree, something we all aspire to achieve in the coming years. And we are truly privileged to have a role model like Dr. Igbineweka speaking to us this evening. There will be plenty of time for questions at the end, and if you are comfortable to, please do request to speak live on air, as Dr. Igbineweka would love to hear your questions directly. So, without further ado, I will hand over to you, Dr. Igbineweka.
Thank you very much, Puru, for that fantastic introduction. I'm very grateful and honored to speak here today. So I'll just share my slides now. Okay, can you see the slides clearly?
Yes, we can. It's wonderful.
Good. That's good. All right, so good evening, everyone, and welcome to this webinar. My name is Norris Igbineweka, and as Puru kindly introduced, I am a clinical research fellow presently doing my PhD in red blood cell diseases at both Imperial and Oxford University. I'm also a hematology registrar at King's College Hospital, and I was previous Fulbright Scholar in 2016. Thank you for tuning to listen in on this topic. It's a topic that is not so much in the public eye of attention, in my opinion, but holds huge significance to biology, medicine, society, and beyond. I would like to thank Brighton and Sussex Medical School Oncology, Haematology, and Palliative Care Society for allowing me to speak on this topical issue during this topical time of the year as Black History Month draws to an end. I have entitled the talk, "The Story of Sickle Cell Disease, a Black Lives Matter Disease or a Glimpse into the Struggle of Humankind." I am aware that I have quite a diverse audience. I have targeted this presentation for the majority medical students, medical doctors, and some experts and professors listening in, but I'm also aware that we have some external lay members of the public, professionals outside the medical profession, family and friends tuning in, which is so fantastic. Some even tuning in from internationally from the USA and Nigeria, so thank you all. Some parts of the webinar can be technical and medical, but hopefully there will be some relevant information for everyone. So how did I develop an interest for sickle cell? Well, my family name is from King Igbineweka II, who reigned between 1914 to 1933, and he was Oba and King of the ancient kingdom of Benin, which has been in existence since the 12th century. It now is part of modern-day Edo State, south of Nigeria in West Africa. In 1897, the British successfully invaded Benin Kingdom on its second attempt and deposed the then King of Arenwem, King Igbineweka, his dad. And in 1914, King Igbineweka rebuilt the royal palace once he regained the throne. He was an avid craftsman prior to his reign, and he restored all the crafts guilds and commissioned objects to replace those that were looted by the British. Some Benin bronzes remain in the British Museum today, and he also started the Benin Arts and Crafts School. And so on the bottom left, that's a picture of King Igbineweka II, Oba of Benin at the time. And on the bottom right is a picture of my granddad, a significant chief at the time of 1981, continuing the family trade of intricate craftsmanship. Top right is my uncle present day continuing the trade, and the middle and top left picture are just examples of the artifacts that will be carved to document Edo history. So in Nigeria, West Africa has a total population of about 195 million people. The sickle gene mutation is present in about 25 to 30% of the population who are deemed to be carriers. Out of that total population, 2 to 3% have the disease, which is about 150,000 children also being born annually with sickle cell disease. In the mid-80s, my parents had me. I was born in Nigeria, and when I was about 15 months old, my parents migrated to the UK, settled in South London in the borough called Southwark, and this was where I grew up. Southwark, according to their census documentation, has the largest migrant group of Nigerians at 4.6% of the population, followed by Jamaicans at 2%. Bami communities in total represent about 32% of the population of Southwark. And according to the demographic data, sickle cell disease prevalence in Southwark is overrepresented compared to that of the rest of England and even that of the whole of London. So I witnessed a lot of individuals affected by sickle cell disease, even close family members when I was growing up. When seeing individuals with sickle cell disease, I quickly realized that this was a devastating and debilitating disease with its acute painful crisis, which were agonizing for the sufferers and carers and families around them. There were often recurrent hospitalizations, and it often meant a life of unpredictability with difficulty to plan your life around pain or another complication that could come at any point in time. I also noticed at the time that it was shrouded in secrecy and stigma. A lot of families who had individuals with sickle cell were often kept as the family secret or something kept discreetly due to many issues you will see later on in the presentation. I was fascinated by its remarkable clinical heterogeneity, i.e. there is no one individual with sickle cell that has the same disease course. All vary in severity. And so some individuals will have lots of pain and hospitalizations, but some will barely get any pain or disruption to life. And this is all despite having the same monogenic abnormality. An amazing biology teacher taught me genetics in secondary school, and from then on, everything just clicked. I knew I wanted to help people medically, but also utilize science and genetics to do this. So unfortunately, I bucked the family trend and to study medicine in King's College, London, and that's a picture in the top right of Guy's campus at London Bridge, although when I attended at the time, the Shard had not been built then. I took a keen interest in trying to understand why there was so much clinical variability in sickle cell, and eventually found that the most biggest powerful genetic modulator was something called fetal hemoglobin. Fortunately, there was a professor who was a world expert in sickle cell disease at King's and in fetal hemoglobin, so I was able to do a lot of research alongside medical school and post-qualification. So what is sickle cell disease? From my perspective, I look at sickle cell disease from a genomic light, and I make a lot of reference to genomics in this presentation. The reason for this is the central and fundamental pathology is a genetic DNA-based substitution. Unfortunately, as you know, the consequence of this genetic pathology extends to, and in terms of the consequences, extends to the physiological, the medical, the psychosocial, the anthropological. Genetics, unfortunately, cannot solve all of these issues, but it does make a very good start in helping to understand and manage sickle cell disease. So sickle cell disease is an inherited condition caused by a single gene mutation, single DNA base change from adenine to thymine, which codes for the beta globin chain on hemoglobin in blood cells. The fact that this happens in a coding region of the DNA is pretty dramatic, as mutations in exons are much less rare than mutations in introns, i.e. between coding regions of DNA. What is even more interesting is that this is a pathogenic mutation, and it is relatively common by genetic standards. This gene mutation codes for an abnormal protein, so glutamic acid is substituted for valine, and this affects the charge and polarity of the molecule and leads to abnormally produced beta hemoglobin, which polymerizes under low oxygen states. The polymer formation of hemoglobin leads to red blood cell changing shape to this overall sickle nature, which you're all familiar with. The sickled red blood cells get trapped easily in small blood vessels in the body, causing oxygen starvation and tissue death, as well as breakdown of red blood cells and local inflammation. This all through complex mechanisms leads to pain for the individual. As well as pain, it is also important to remember that sickle cell disease is a multi-system disorder. So anywhere that can be reached by the blood circulation carrying sickle cells, it can cause damage, particularly in the small blood vessels. So this is exactly the pathophysiological process that occurs in, for example, avascular necrosis of the hip joint, where there is a sickle cells block the singular blood vessels to the hip bone, causing bone death. For the individual, that means walking with a painful limp in the hip. And these processes affect the brain, so you get stroke and organs like the kidneys and the lungs. So the bottom picture on the right, we have two x-rays, one of a healthy hip on the left and one on the right where there's avascular necrosis, bone death. As a result, the femoral head has collapsed and there's loss of natural joint space, leading to increased friction and pain for the individual. So this is what we see as hematologists when we're looking at a blood film. We take blood, we spread it on a slide, stain it with a certain stain, and the picture on the left shows a normal or healthy blood film. And you can see that there's plenty of small spherical red blood cells, which are the optimal shape for delivering tissue, oxygen to tissues. And the red blood cells look red, which indicates healthy iron stores. In comparison, the blood film on the right is someone with sickle cell disease. And I hope you can appreciate that there is less red blood cells in general. So there's more white spaces indicating less red blood cells, indicating anemia. There's also red blood cells which have a lot of white inside them in itself, highlighting that they're poorly hemoglobinized and they're not making hemoglobin well. And we can also see what we call polychromasia, and this is where the red blood cells turn a bluish tinge, just as they're being released prematurely to keep up with excess loss of red blood cells. There are also things what we call nucleated red blood cells, and this is usually, so normally mature red blood cells enucleate, so they get rid of their nucleus. But we see in sickle cell disease that the red cells are retaining their nucleus, again emphasizing the immature cells being churned out of the bone marrow under stress just to keep up with excess demand. And then finally, I hope you can see in that blood film on the right, the elongated bone banana-shaped red blood cells, which are the sickle cells and are pathognomonic for sickle cell disease. So these are a few celebrities with sickle cell disease. On the bottom left, we have Lawrence Tate, he's an American actor. Top left, we have Tika Barber, he's an American NFL player. And at the top right, we have T-Boz from a TLC girl group. And the bottom right, we have the famous jazz musician, Miles Davis, all having sickle cell. So as you would probably know, the geographical spread of sickle cell has been associated with malarial endemicity. It's not necessarily the case that having sickle cell traits or carrier status protects you from getting malaria, because there are many people who have sickle cell traits that still get malaria. However, what it does do is protect you against severe forms of malaria, like cerebral malaria. Consequently, the sickle cell is found in predominantly areas like sub-Saharan Africa, North and South America, India, Middle East, due to gene presence and population history. There are 5 main distinct beta globin haplotypes where they are found due to a series of genetic variations which have been associated with sickle cell and had been inherited down generations. These are Senegal, Benin, Bantu, Cameroon, and Arab Indian haplotypes. Senegal and Arab Indian haplotypes are said to be more milder in phenotype compared to other haplotypes. Sickle cell disease is the most common genetic hemoglobinopathy internationally. In Africa, there's estimated 6 million people affected with sickle cell disease annually, and over 275,000 children born each year with sickle cell. 80% of the world's global sickle cell disease burden is in Africa. In the UK, there are about 12,500 to 15,000 people living with sickle cell disease and 240,000 carriers of sickle cell. So in terms of population genomics and copy number variation, which are large structural inherited variants, so they comprise of things like deletions, duplications, and inversions on DNA. It describes what we were doing as humans or Homo sapiens, and what that shows is that we were actually all in Africa about 200,000 years ago, and there was extreme genetic diversity then. And Homo sapiens spent quite a long time in human history just being in Africa, where the diversity grew. And about 100,000 years ago, a much smaller pool of Homo sapiens left Africa to populate the Middle East. And the smaller population had a much smaller pool of genetic diversity and variation compared to the African population. This population eventually moved east to India and China 70,000 years ago, and eventually the population then moved north to Europe. And we see this on copy number variance analysis or something called runs of homozygosity. So similar to the runs that you get with, say, Huntington's disease, CAG repeats. These are sort of larger runs of homozygosity on DNA. And the longer these runs on DNA signifies the further away you get from Africa. And this also bears some relevance to the Judeo-Christian story in the book of Genesis, where there was a united human race in the generations following the Great Flood, and everyone was supposedly speaking a single language. They were said to migrate eastward and eventually reach a land called Sinai, which is modern-day Iraq. And there they agreed to build a city or a tower, which was apparently tall enough to try and reach heaven. God then confounds their speech and they can no longer understand each other and scatters them across the world. In terms of the origins of the sickle mutation, it also confirms this out of Africa hypothesis. Initially, it was proposed that the sickle mutation arose independently in those areas where I mentioned regarding the 5 distinct haplotypes. However, this was disproven about 2 years ago and published in the American Journal of Human Genetics by a team at the NIH, using historical records and analysis of genomes close to about 3,000 people with genetic history of the disease. They were able to pinpoint that the most likely time and place of origin, they labeled the Green Sahara Zone, which was somewhere in West Central Africa, about 7,300 years ago. And they deduced that at some point in history, that the sickle mutation could actually be traced to one African person. And at about this time, this person would have been born with a genetic mutation on one chromosome. This person wouldn't have suffered any symptoms because the other gene would have been perfectly normal, but he or she would have grown up and had children of their own, thus passing the gene to the next generation. The mutation would have endured, passing on hundreds of years before one unfortunate child would have had to be born with 2 copies of the mutation and therefore developing sickle cell anemia. The first recorded cases of sickle cell anemia in history occurred in Egypt in the pre-dynastic period around 3200 BCE. Given the first documented evidence of the sickle gene mutation is around 3200 BCE, and the first documented evidence of malaria was about 4,000 to 5,000 BCE in China and Egypt, it is consequently hypothesized that the environment of malaria endemicity played a selective factor in the sickle gene developing. And due to population migration and Bantu migration, sickle cell disease would have traveled to other parts of Africa and then other parts of the world, including the Near East, Middle East, India, developing along the way into different subtypes. And it's likely that there was a Sudanese and Egyptian haplotype then. Eventually, slavery and migration would allow for the mutation to be prevalent in North and South America and Europe. So following on from ancient Egypt, there was documented evidence of sickle cell disease in the Persian Gulf during the Hellenistic period, about 2,130 years ago. And it was later documented in West African tribes, for example, the Ga tribe in Ghana, 1670 AD, concepts meaning relentless or gnawing pains in the bones and joints, or Obanje in the Igbo tribe, or Abiku in the Yoruba tribe, took on more negative spiritual connotations, meaning children who were malevolent spirits that will come and go, only to come back and be reborn and cause repeated cycles of grief to their families. And these children were said to have sickle cell disease, not even reaching the age of 5 years old. The top right picture was of me, this about 15 years ago now, when I visited a traditional herbalist for sickle cell disease in the Oyo state, in the Yoruba tribe, and I examined how they manage sickle cell disease. They tend to use a herb-based method to treat sickle pain, some of which is ineffective, but some herbs like Niprasan, which is a combination of black guinea pepper, capsaicin, and Cajun spices, have been shown to have some marginal effects in African research studies in reducing pain episodes. The problem with this was that a lot of these herbs caused inhibition of the cytochrome CYP3A4 activity, so they would be contraindicated with a lot of drugs that are or interactions. However, Nipasan was awarded orphan drug status by the FDA, but due to financial barriers, the production was halted, and so Nipasan has not progressed to clinical trial. And I did a bit of anthropology work back in the day as well, and so I focused, some of it looked at individual experiences of sickle, their phenomenology, and it led me to describe their state as being liminal beings, that is individuals that occupy two worlds or two realms and navigate between the sick and the healthy. And sickle patients often have to navigate between hospital and being out of hospital, and just understanding how they did that so successfully. So given all the information we know now, is sickle cell disease only found in Black people? Given that it's the most predominant disease in Africa and Arab countries and India, can we conclude that sickle cell disease is only exclusively in Black people? First of all, on a more practical note, a disease like sickle cell disease at the level of genetics is not restricted to the relatively simplistic categories of skin color and race we have today. At the level of the genome, we see that functionality is the most important thing if you are a DNA base trying to make a protein. Due to the effects of slavery and present-day migration, sickle cell disease can actually be found in Caucasians, albeit at very lower prevalence. Dr. Steve Jones, a leading geneticist in UCL 1999, found increasing numbers of white babies born each year carrying sickle cell anemia traits due to hidden Black ancestry. Extrapolating from 16th century census data, he was able to calculate that 11 million people, so 1 in 5 Britons who think of themselves as white, had sickle cell traits. Therefore, most certainly have a Black ancestor. Also, increasing numbers of mixed race relationships mean the disorder is moving into the white population silently in people who do not know that they are carriers, leading to an increasing number of carriers and homozygous sufferers. So on the bottom right is the independent newspaper report for a Mrs. Pryor, 35-year-old lady, trainee accountant, who at the time actually was living in Brighton, who was Caucasian. She went to donate blood to the National Transfusion Service, and they wrote back saying they tested her blood for donation and found she had sickle cell traits. She then told her mom got tested and found to have the traits as also. They were able to trace their ancestry back to a Jamaican sailor who settled in Liverpool in the 18th century. The top right shows a case report published in the Journal of Pediatrics 1979 of 2 white American children born with homozygous sickle cell anemia. And the top picture of the children on the top left both have sickle cell beta thal. So the moral of the story is that we can't take things at face value. One of the figures I designed in a paper that we published, and I just we published a few years ago, was a timeline of the historical milestones in the Western world regarding sickle cell disease. The first clinical description of sickle cell disease was described in 1910 by Dr. James Herrick, a pediatrician treating a Black Grenadian student who was complaining of fatigue and pain. When he took his blood, he looked under the microscope and he observed these sickle-shaped cells. And it was not till the 1940s and 50s when sickle cell disease was then characterized as a molecular disease, where the abnormal protein was defined by abnormal genes. And then since then, sickle cell disease has been used as a model and poster child for molecular genetics. In the 70s, Khan and Dozy was able to use the sickle gene to test out the development of the technology of what we now know as prenatal genetic diagnosis. In the 90s, we see evidence for the introduction of prophylactic penicillin, which reduces early death through the prevention of infection. And in the early 90s, we also see a trial showing the daily use of hydroxycarbamide or hydroxyurea as beneficial in reducing painful crisis and preventing sickle cell disease complications. More recently, we now have gene editing techniques where we can now replace the faulty gene and substitute it with a normal gene. This is certainly promising, but challenges remain and refinement is needed in the ability for the new vectors to be sustained. Other issues include the prevention of off-target DNA effects, and other issues include pricing, as these gene editing tools cost about $1 million from start to finish, so unlikely to be available for the bulk of where it's needed in Africa. Some of my previous work showed that in Western countries with advanced healthcare systems, patients with sickle cell disease are living longer, and we are mainly witnessing a transition of sickle cell disease where patients who would have had early mortality in childhood dying of infection. Now, a lot of these patients are living well into their late adulthoods. Average life expectancy in the developed countries has moved to about 50 to 60 years. So there has been a shift in the perspective, not only dealing with acute causes of mortality, but now seeing and managing sickle cell disease as a chronic condition. This graph just shows that in Western countries, like the UK and US, individuals with sickle cell disease are living longer, and this is mainly due to improvements in comprehensive multidisciplinary healthcare structures, which ensure optimum sickle cell disease care involving things like prophylactic penicillin, folic acid, blood transfusion, and hydroxycarbamide therapy. There are two important caveats to this, however. It is important to note that the average lifespan of persons with sickle cell disease in the UK and the USA still remains 3 decades shorter than healthy individuals. And secondly, mortality rates in areas in Africa for children for sickle cell disease under the age of 5 is still anything between 50 to 80%. In terms of genetic diagnosis, genetics has been used to help sickle cell disease management. Mandatory premarital counseling has been used as a strategy in some countries to effectively reduce disease burden. In Bahrain, for example, couples are required to know their hemoglobinopathy genetic results before getting married, and this has been associated with a 50% decrease in sickle and thalassemia cases. Nevertheless, this is obviously fraught with many ethical issues. Chronic villus sampling and amniocentesis are both methods you can use to diagnose sickle cell disease in the fetus during pregnancy. This serves to give information to parents during pregnancy to guide decisions around the knowledge of diagnosis, to prepare and give possible information for termination of pregnancy if deciding that option. Whilst this is an alternative means of management in sickle cell disease in the Western countries like US and UK, this has not really taken off or assimilated well in Africa, largely due to its religious nature. There are newborn screening techniques as well, which has been around for a while and has been very successful in Western countries like the UK. And recent data suggests that when implemented well in Africa, it can also lead to better outcomes for these patients, as you're able to follow patients and manage them along the way and prevent them from getting complications. And there are more semi-recent IVF-based techniques, such as prenatal implantation genetic diagnosis, that allow you to select for the sickle gene 5 to 6 days after fertilization. You pick the embryo that does not have sickle cell disease and put it back into the woman and proceed with the rest of pregnancy. So the first human genome was sequenced in 1990 and completed in 2003. So almost 20 years has gone by since that happened. So the question could be posed, where was the impact of this genomic or genetic revolution for sickle cell disease? We have had several forms of genetic studies since then, such as family linkage studies based on family studies, candidate genes approaches, so these are sort of genetic association studies which look at genetic variation within pre-specified genes of interest, genome-wide association studies, and these look at common genetic variations, particularly for complex diseases. We've had next-gen sequencing platforms which utilize whole genome sequencing and whole exome sequencing. We've had the 1,000 Genomes Project, which is an international effort on genetic variation. That project did have about 130 Yoruba patients in Nigeria, from Nigeria. There are 100,000 Genomes Projects, which is in UK, and HapMap projects, so several genetic studies. All of these avenues have yielded some benefits, but not the greatest impact we were expecting. And what has been observed that over the past 20 years, these genetic studies have been skewed to using more European populations and not enough African populations, especially for genetic studies. While it is good to use these studies, what probably wasn't such a good idea was to largely leave African populations out, especially knowing the African historical genetic context that I mentioned before. To analyze genetics, particularly for disease like sickle cell disease, you need the African genome as a reference or benchmark genome in order to make accurate deductions on genetic variation you see. And this has not only delayed progress in sickle cell disease, but also that of humanity, I think. And this in recent years they've been trying to rectify it, and with the H3 Africa study, and this has yielded impact in non-communicable diseases like hypertension, stroke, and chronic diseases, and communicable disease like HIV, and even sickle cell as well. And there is more data to come for sickle cell disease. Things like APOL1 gene mutation has been found to be associated with sickle cell nephropathy and chronic kidney disease in African populations. So sickle cell disease is unique in its characteristics, as it holds qualities for both a monogenic disease, just like any other autosomal recessive single gene disorder like cystic fibrosis or Tay-Sachs. But at the same time, it has heterogeneity or disease variability. As I said before, some patients get very ill and with frequent hospitalizations, and some patients have very minimal complications. And this is almost akin to complex disorders with multiple genetic influences like type 2 diabetes or atherosclerosis, for example. In this regard, the clinical course of someone with sickle cell disease is highly susceptible to environmental influence. For example, the life expectancy of someone living in sickle cell disease in the UK is not the same as someone living in Africa with sickle cell disease. And this is purely the environmental influences. In terms of the pathophysiology, in hypoxic states, states that lack oxygen, these red cells become rapidly but reversibly deformed. Intracellular polymerization of abnormal sickle hemoglobin stretches red cells into this rigid sickle form. And sickle cells cause vaso-occlusion along with other cellular and plasma factors interactions. And there's this repeated cycle of ischemia and inflammation, and reoxygenation restores the normal red cell shape. The sickle oxygen affinity is also shifted to the right in order to allow for oxygen to be delivered more readily to tissues. And so therefore, individuals with sickle cell disease can run at low baseline levels of hemoglobin naturally and tolerate chronic anemia more so than those without the disease. And sickle cell disease, as I said, is a multi-system disorder, a multi-organ disease. The main pathophysiological mechanism is that of sickle vasculopathy. And this is the ongoing damage of sickle cells affecting the vessels. And it's a silent killer because you are getting silent, irreversible process of sickling going on in the background. And so I always inform my patients with sickle cell, getting rid of sickle cell pain is one thing, but you need something to slow the silent or this process down. What you need is a disease-modifying agent like hydroxycarbamide or blood transfusion. On one side, you have vaso-occlusive crisis causing inflammation and tissue death, and the red blood cells become more sticky, hypercoagulable, and there's increased risks of forming blood clots. On the other side, there's increased red cell breakdown, hemolysis leading to anemia, and this allows for free hemoglobin, which is toxic. And this is released from the red cell breakdown. And this free hemoglobin scavenges nitric oxide, and therefore there's increased vascular tone. And that also allows for things like increased platelet upregulation, increased vascular resistance, and endothelial dysfunction. And all of this constitutes part of the vasculopathic damage, which causes multi-organ damage, affecting eyes, the brain, lungs, hearts, liver, kidneys, bones, skin. Longitudinal studies for adults with sickle cell disease show approximately 1/2 of surviving patients by their 5th decade had some form of irreversible damage to lungs, kidneys, brain, or retina, and this affected their quality of life. One of the biggest causes of chronic morbidity and mortality in sickle cell is cardiopulmonary related morbidity and mortality, and that accounts for 50% of mortality in sickle cell disease. Amidst all the doom and gloom, nature has left us a clue for redemption. Fetal hemoglobin is one of the most powerful biological tools in terms of predictor of severity and treatment in sickle cell disease. And fetal hemoglobin has had a long-standing established biological and clinical role in hemoglobinopathies, where fetal hemoglobin is known to influence disease severity in both sickle cell and beta thalassemias. So just a quick reminder of fetal development. There is an initial first genetic switch from embryonic to fetal hemoglobin around 6 to 8 weeks gestation. Then there's a second switch just before birth from fetal hemoglobin to adult hemoglobin. And fetal hemoglobin in normal adults is produced only in negligible amounts in life in healthy adults, but tends to be increased in disease states, for example, like MDS or myeloproliferative disease. And you can also get residual HbF in any form of hematopoietic stress. In sickle cell disease, we know that there's a higher residual baseline fetal hemoglobin due to the shortened lifespan of sickle cell hemoglobin. And we know that the higher the fetal hemoglobin levels, the less chance of sickle cell disease complications. And this is purely because fetal hemoglobin inhibits sickle hemoglobin polymerization. We have also known that if we can get individuals with sickle cell disease to a fetal hemoglobin of between 20 to 30% in all red blood cells, what we term as pancellular, we could effectively cure sickle cell. With beta globin switching, gamma chain transcription responsible is silenced by DNA promoter methylation, with beta globin gene itself becoming demethylated and activated. And that's why we look at hypomethylating agents like decitabine and azacitidine, which induce levels of fetal hemoglobin. Fetal hemoglobin is also produced primitively in the embryonic yolk sac in fetal development, and this migrates to the aortogonad mesonephros region, and then migrates to the liver and spleen, and then to the bone marrow just around birth, when you get that second genetic switch to adult hemoglobin. And fetal hemoglobin was discovered by von Kober in 1866 when he noticed that umbilical cord blood withstood denaturation from strong acids and alkalis. And this was in contrast to adult blood, which quickly degraded. And over the past few decades, there's been huge interest to modulate and upregulate fetal hemoglobin, particularly in the sickle cell disease world. And this really started after the New York hospital pediatrician Janet Watson observed in the late 1940s that newborns with sickle cell disease did not manifest any clinical symptoms till later in infancy. and then usually then developed a pain and swelling around their hands called dactylitis, like the picture above. And this was attributed to the protective effect of fetal hemoglobin, which then declined as fetal hemoglobin declined as the child got older. Later clinical studies show that patients with sickle cell disease, both adults and children with elevated fetal hemoglobin, had fewer pain crises, improved survival, and these studies also identified drugs like hydroxycarbamide, azacitidine, as I said, which are beneficial to the prognosis of sickle cell disease and beta thalassemia. In the millennium, we saw a plethora of genetic studies dissecting the regulation of fetal hemoglobin, and this understanding is now being used for one of the gene therapy strategies in sickle cell. So just a small bit on the genetic regulation of fetal hemoglobin. When we dissect it, we see that fetal hemoglobin is a heritable trait with 89% of its variants ascribed to genetic factors. And through 2 decades of meticulous work from Profane's previous lab at King's and Dr. Stuart Hawkins' lab at Harvard, we now have a good understanding of the genetic regulation that is responsible for about 40% of the variants. There are 3 main single nucleotide polymorphisms, or what we preferably call quantitative trait loci, responsible for the regulation of fetal hemoglobin. The first one is HbS1l MIB, which is an intergenic polymorphism on chromosome 6, and this was discovered with genetic analysis linkage studies of a large Asian Indian consanguineous family with beta thalassemia and a condition called co-inherited hereditary persistence of fetal hemoglobin. And this genetic condition causes deletions or point mutations in the gamma promoter of the beta globin cluster, allowing for increased levels of fetal hemoglobin. And this region spans about 79 kilobases between HbS1l and MIB. And these polymorphisms are arranged in what we call free linkage disequilibrium blocks, which are sort of a non-random association of alleles at different loci. And those blocks can be seen on the bottom right of the page. And HbS1l MIB, the second block, has the strongest effects on fetal hemoglobin. And this intergenic region is important for the interaction of key transcription factors like GATA and KLF1, which modulate MIB and influence erythroid differentiation. The second quantitative trait is BCL11A, probably the most popular, and this gene codes for a zinc finger protein, and a genome-wide association studies picked this loci when they examined a cohort of 179 Northern Europeans with contrasting extreme F cell values. BCL11A is also known for its involvement in lymphocytes and neural development, and it's seen as the master regulator of fetal hemoglobin and has had a direct effect on gamma globin expression. And also interacts with transcription factors like GATA and KLF1. And finally, the last quantitative trait is XMN1, and this is on the beta globin cluster on chromosome 11, and this was identified about 30 years ago. And all of these QTL are associated with HbF levels in healthy populations and as validated in various different populations with sickle cell disease, beta thalassemia, inherited bone marrow syndromes of various ethnicities. And these QTLs have been shown to be associated with milder phenotype and reduced severity in sickle cell disease and beta thalassemias in various populations. And as well as regulate fetal hemoglobin, these QTL also affect hematopoietic kinetics and alter and influence other hematological parameters. So HbS1l MIB has been associated to influence hemoglobin, MCV, platelet levels, and monocyte counts. And they, as I said, they only, altogether, they explain about 30 to 40% of the variability. So there's still 60% of the variability waiting to be discovered. While I was at Brighton, in a study I did with Dr. Chevassut, I was able to demonstrate the extended pathogenic role for fetal hemoglobin QTLs in hematological malignancies. such as myelodysplastic syndrome, myeloproliferative disease, and myeloma. This graph shows the pathological difference in mean allele frequency in our disease population compared to the general British population control group. Most pathological difference was seen in the first column, with one of the SNPs in HBS1L MIB in MDS as represented by the orange diamond, and control population represented by the brown circle with hugely divergent mean allele frequencies. BCL11A is, as I said, probably the most well-known, and knockdown of BCL11A increases fetal hemoglobin levels. However, when this was done in mice in the early days, the side effect of knocking down BCL11A was intellectual disability and neurodisability syndromes. And it also disrupted lymphocytes, as BCL11A also regulates neurogenesis and lymphopoiesis. However, this important paper by Dan Bauer and Stuart Orkin's group at Harvard, published in Science, I think 2013, they were able to find an erythroid-specific enhancer which regulated BCL11A, but was only expressed in red blood cells. So therefore, when BCL11A was knocked down, they avoided the effects of neurogenesis and lymphopoiesis. And this finding paved the way for BCL11A knockdown strategy for the development of fetal hemoglobin induction in gene editing. Some other known genetic modifiers in sickle cell, perhaps less well spoken about, is actually the co-inheritance of alpha thalassemia. So if you inherit deletions for the alpha hemoglobin in combination with sickle cell, you are likely to do better. You are likely to have delayed complications. You're likely to have better hematological parameters and longer long-term survival. And this is because having less or no alpha chains in sickle cell gives less opportunity for the sickle polymers to form. Indeed, we have known that BCL11A and alpha co-inheritance is important to lessening things like risk of stroke in both children and adults with sickle cell disease. Other strong genetic associations are APL-L1 and MYH9 for its increased risk to sickle cell nephropathy and chronic kidney disease amongst African populations. And HEMOX1, oxygenase 1, has been implicated in the development of acute kidney disease, as well as acute chest syndrome, one of the very big causes of acute mortality in sickle cell disease. So a very nice study that was published this year actually by Prof Wellcome's group in Cape Town, South Africa, and Charles Rotemy's group in NIH. This was on the concept that, of course, we know that sickle cell disease is bad. We know that Africa has a high childhood mortality, but every now and again, we have people who defy that order of logic. So it's not too surprising when you have an African, what I term grandma, who is 90 years old and has lived in Africa all her life. She's homozygous for sickle cell disease. And she looks you in the eye and says, she's never required treatment. She's never had hydroxycarbamide, never had blood transfusion. And she tells you she swears by her favorite herbs and spices. And so what Prof Wellcome did was they garnered a group of these similar type of patients, what we term in genetics as similar phenotype, and then performed whole exome sequencing, which was sequencing of the coding regions in these African long-term survivors. They defined long-term survivor as patients who are more than 40 years old, which is by long-term survival by African standards. And they found mutations in CLC N6, which was associated with lower blood pressure. And we know that high blood pressure is a risk factor for stroke. So this is quite interesting. So these individuals probably live longer due to reduced risk of stroke. They also had found mutations in OGHDL, which is important in arginine metabolism, which is a key factor for hemolysis endothelial dysfunction in sickle cell disease. And it's quite interesting to see that we've recently had a clinical trial which shows some benefit of L-glutamate and arginine, so that lowers sickle cell pain and sickle cell pain in clinical trials. So there is a sort of a biological basis now for this. And then we also see that gene variants involved in complement and coagulation and the fibrinolysis pathway are adversely affected in the development of stroke. So SERPINC1 gene, which encodes for antithrombin, as well as C5 mutation, have all been implicated in stroke development. Lastly, and interestingly, genes implicated for starch and selenium pathways were also found to have a protective effect, but these lines of inquiry have not been investigated yet. Starch is very interesting, as we know some tribes, like the Igbo tribe, have foods like yam as a major part of its diet, so that could be a very interesting line of inquiry. This study should have gone into the Lancet, but because of its significance, but did not go as a result of its lack of patient numbers, so was published in the Clinical and Translational Medicine Journal. And I'm informed by the authors that they are already replicating this study with larger numbers this time and are seeing exactly the same results, and will publish these results soon. So this is a picture of Madam Onikoyi-Laguda. She lives in Lagos, and she has sickle cell disease. She's presently 95 years old, so definitely an example of a long-term survivor. In terms of acute painful crisis, this is the principal morbidity in patients with sickle cell disease, and it presents as excruciating pain episodes for individuals, leading to recurrent hospitalizations. It is a symptom iceberg. So most of the pain episodes that these individuals have are dealt with at home. So presentation to hospital often means that the pain is severe enough for them to warrant to go to hospital, except in a small number of cases where there is high opiate tolerance. Acute pain crisis is also sort of predisposed to increased hospitalization rates, chronic multi-organ damage, and poor quality of life, as well as increased risk of mortality. There is also an economic burden as well. So a retrospective analysis of about 6,077 admissions related to sickle crisis as a primary diagnosis in England, 2010 to 2011, cost the NHS £19 million that fiscal year. And in the state of Illinois, they analyzed that 8,400 sickle cell admissions with about 11,000 patients with sickle cell over a 2-year period, and found that admission costs were about $59 million for those 2 years. An average lifetime cost of care for a patient with sickle cell disease is about $460,000 for about 4,200 patients with sickle cell disease enrolled on a Florida Medicaid program. And just to remember, although we see acute painful crisis as clinicians most of the time, it is important to be aware of the complication that can cause the highest mortality rate, which is acute chest syndrome. And this carries a mortality rate of about 30%. And this complication is caused when sickling acutely goes to the lungs, and it's much rarer than acute pain crisis, but it needs to be recognized very quickly and acted upon. There is a list and range of acute and chronic complications in sickle cell. This ranges from neurocognitive dysfunction and stroke, to sickle in the eye, to lungs and pulmonary hypertension, to heart failure, and affecting the liver and kidney, as well as gallstones. One of the big ones is the increased susceptibility to infection and septicemia, and which is why because sickle patients often have poorly functioning spleens, and they are at risk of pneumococcal infections. And that's the reason why they have pneumococcal injections, vaccinations every 5 years, and the majority still take penicillin prophylaxis. In the Western world, this reduction in infection rates is one of the big reasons for the increase in life expectancy. And I always often tell students that this list is not exhaustive. And if you want to, when dealing with patients with sickle cell, just recognize that they can develop any complication at any time, like any other medical patient, but they also have these specific sickle cell related complications as well to look out for, and they can deteriorate quite quickly and rapidly. So in the UK, we have routine clinic reviews every 3 to 4 months at specialist sickle cell centres, and updated guidelines have meant that all patients should have a sickle cell care plan. So when they attend the emergency department, it should be clear what painkillers are necessary for which individuals, or for example, what antibodies may be present in certain blood, individual's blood, so that you're careful if you give the individual a transfusion or not. So it shouldn't matter what hospital they end up in the country, they should be able to receive initial appropriate management. And all patients should have an annual review, and this is mandatory as we assess for key things like how many crises are patients having in the year, and if it's more than 3, we may need to offer a disease-modifying agent like hydroxycarbamide. We assess for things like iron overload caused by excess transfusion. We do things like echocardiogram for the heart, ophthalmology screen, joint and skin assessments, as well as blood tests and vaccinations. And we do transcranial Doppler screening to prevent stroke in children. And we also have a national hemoglobinopathy registry where we register patients for sickle cell for research. And it is because of these strategies why life expectancy is improving in the West, and the ability to have this access, comprehensive access through their hematologists. In terms of therapies, I've put analgesia in brackets because that's just a symptom reliever, but blood transfusion and hydroxycarbamide form the staple base of our modifying therapy. Both are generally good. Some modalities are better than others for certain complications. So we know that red cell exchange blood transfusion modality is the optimum modality for preventing stroke, for example, or especially children with high transcranial Doppler screen or individuals who have had stroke in the past. And blood transfusion works effectively by diluting sickle cells with normal blood. If you are experiencing increased pain crisis, we tend to start with hydroxycarbamide if you can tolerate the hydroxycarbamide, and we like to, because that essentially increases your fetal hemoglobin and hopefully gives you better improvement, but you've got to increase the hydroxycarbamide at maximal tolerated dose. Blood transfusion can also lower your pain episodes, but we tend not to start with blood transfusion, as blood transfusion also comes with risks and side effects such as iron overload, increased risk of infection, and the risk of forming antibodies, making it more difficult to have a transfusion in future. In the past, we tended to be in the UK, have some reluctance in using hydroxycarbamide due to concerns about infertility. And also because hydroxycarbamide is technically a form of chemotherapy, there was a presumed risk of it could be carcinogenic. But anytime I went to the States, for example, there was very good uptake with hydroxycarbamide, and individuals who took hydroxycarbamide tended to have what we call the hydroxycarbamide smile as the pain episodes lessened. And Americans were very keen with hydroxycarbamide. They started in all babies with sickle cell disease to prevent complications down the line. And this is confirmed in one of the clinical trials called Baby Hog Study. UK practitioners have now switched to the USA approach in trying to offer more patients with hydroxycarbamide. There was a previous feeling by UK doctors when they tried hydroxycarbamide in the past with their patients that they weren't getting the same clinical effect. But it turns out we weren't actually given the appropriate dose of hydroxycarbamide to have a good effect. And it's important that you push the hydroxycarbamide dose to maximum tolerated dose. And we are seeing longer term studies which are not really showing significant carcinogenic risk or even effect on infertility. There was reduced sperm in mice, but not really anything in humans. However, we still do sperm banking just in case, and we still stop hydroxycarbamide prior to pregnancy in women. Hydroxycarbamide has also been shown to recently work effectively in the African-based setting, as it's just an oral tablet. You just monitor the counts every so often for myelosuppression. So moving on to newer agents, crizanlizumab is a monoclonal antibody which targets P-selectin in the coagulation endothelial pathway, and it essentially makes cells and platelet interaction less sticky. And it has been FDA approved, but we're waiting NICE approval, hopefully I think in January 2021. And this has been shown to effectively reduce frequency of sickle cell acute pain crisis. We also have voxelotor or anti-GB440, and this is an oral drug which increases the affinity of hemoglobin and oxygen, therefore preventing deoxygenation of sickle and thereby inhibiting sickling and polymerization of red blood cells. Again, it has USA FDA approval, awaiting NICE approval in the UK, and it, as well as reducing sickling, the main effects we're seeing is that it improves hemoglobin without the need of a transfusion. L-glutamate has been shown in randomized controlled trials to reduce sickle crisis and length of hospitalization. The limitation is that there was a high rate of dropouts in the study, and there was fatal events in the L-glutamine arm with multi-organ failure. And there's also a lack of effect on hematological parameters. But you can imagine this is also quite an interesting approach because it's easy to take, so you can take supplements as well. And now in the study that was done by Prof. Wellcome, we see a biological basis for L-glutamate. And the final two are potentially curative options, stem cell transplants, but however, this is limited through the availability of you need a leukocyte antigen HLA match sibling donor, and there's also toxicities around myeloabrasive conditioning with chemotherapy, although investigators are trying to improve these methods, but there's still these obvious risks still there. And then gene therapy, there's two main methods. There's a substitution-based method for the DNA basis, and then the upregulation of fetal hemoglobin through knockdown of BCL11A. Both are working well. Published in the New England Journal of Medicine, been successful in a few patients. It essentially turns a sickle cell disease patient into a sickle cell trait patient. And but the question is, how long will they be able to maintain these new vectors? And will they sort of experience off-target effects? And as I said, it's very expensive at the moment. So in terms of what can we say about stigma, disparity, and discrimination in sickle cell disease? Well, it is well documented in the literature of racial disparities in the management of sickle cell disease, and this has been recently published in this year's New England Journal of Medicine article. Disparities include things like sickle cell research funding, sickle cell disease patient care, and life expectancy. And the authors evaluate that cystic fibrosis, another monogenic disease which affects 1/3 less people compared with sickle cell disease, they actually receive 7 to 11 times more research funding. And common problems have also been identified by NICE, who have said there have been unacceptable delays in sickle cell pain episode management, receiving appropriate analgesia, and insufficient analgesia or excessive doses of analgesia, and also stigmatizing patients as being drug seeking. Specialist centers giving comprehensive care, as you moved further away from the center, the hospital that you did attend, the patients often felt that it did not match the expectations or standards that they were used to. So now we have a kind of a hub and spoke method where the specialist care hospitals are meant to liaise and help and be a reference point to smaller hospitals in terms of learning how to manage sickle cell disease and train professionals with up-to-date management in this. And then also there's also patients are felt that they're not being believed when they're in pain. They don't look like they have the disease. They have negative labels like drug seeker, drug addict, sickler, especially if it's a predominant Black population. These semantics can stick more deeply. And mental health is well known that living with chronic condition is going to affect the mental health, being in pain most of the time or being in hospital most of the time. And there's also a lack of understanding on a wider basis. For example, housing for these patients. Some patients are put in the cold and damp environments, which trigger crisis and predispose to infections. Councils don't often understand what sickle cell is. Employment, due to the frequent nature of pain episodes, employers shy away from employing patients with sickle cell disease, again, due to lack of understanding. And there's difficulties even getting things like life insurance. No insurer wants to cover that risk. It's difficulty getting mortgages, and home ownership can also be difficult. And individuals with sickle cell also face stigmatization by their own families or own communities. Still, in some circles, is not something that people want to talk about much. So coming to a close, some of my unmet needs in sickle cell disease, these occupy the full spectrum of biopsychosocial realms. We need more genetic predictors of clinical severity and treatment, for example, and it would be good to have a marker or markers that we can robustly predict severity and clinical course that could determine treatment. We need translation of the genetic markers into druggable targets and eventually development of robust polygenic risk scores. We need more clinical biomarkers and more evidence-based research, particularly randomized control trials in many of the clinical gaps in the management of sickle cell disease, for example, in managing priapisms, which are like painful erections, or leg ulcers, for example. We need more predictors and diagnosis for pain crisis itself. Till today, we cannot definitively say that somebody is having a pain crisis. There is no biochemical test that tells me for sure that someone's having a pain crisis. Of course, we have some markers that could guide us, but we can't actually say for sure. So presently, provided you have a diagnosis of sickle cell and you say you're in pain, then we take your word for it. And we can't even tell where the crisis is coming from, for example. So one of my feelings is that there will be a refinement in some biofeedback sensory technology, and we'll be able to detect these physiological changes more closely and more intensely. We need more therapeutic options, obviously. That includes the need to move away from opiates. We've been using opiates for patients with sickle cell disease for more than 100 years. It masks their pain, but it does not matter who you are. With those frequent high dose opiates, you're bound to build up opiate tolerance, and you're going to be at risk of opiate toxicity. We need refinements of stem cell transplantation techniques and gene therapy. And although sickle doctors are trained hematologists, so they have dealt with transplants in the past. However, traditionally, when one became a sickle doctor, they didn't quite look after transplant patients so much. But now with sickle patients having more and more stem cell transplants and gene therapy, it'll be interesting to see how the clinical responsibilities adjust to that, or it may just remain that the patient is under the joint care of a joint sickle and transplant team. We also need expansion of the donor pool and for blood transfusion and stem cell transplant. And presently, there's a great plethora of research being done in the USA, but UK research grant funders need to find sickle cell disease attractive again. It is an important condition for many reasons I've mentioned. We also have a sizable population in the UK, and it is important to show how the UK environment continues to modify the sickle cell disease phenotype. I believe the sickle cell community also needs a greater political voice. This is something I've seen happen in the US. Sickle cell disease has a White House lobbying group through the American Society of Haematology. And I think it would be imperative for the medical community here to come together with patients, Sickle Cell Society, and other sickle cell disease interest groups and faith-based groups who already provide support for these individuals in the community to form a greater political voice. There is also need for greater psychosocial support and understanding the wider elements as with housing and employment. As I've said before, it's harder for these patients to gain these type of things. So we need greater sensitivity, empathy, and compassion, which are apparently human attributes. And if you are in hospital, with great sickle cell disease nurses, with a social and psychological support structures, then that is excellent. So this is essentially my Christmas wish list for sickle cell disease. And anyone who feels that they have a good idea to develop any of these ideas, I'm happy to help and collaborate with. So in conclusion, the story of sickle cell disease reveals remarkable beauty of individual resilience and adaptation, as well as great feats of medical science. This is often juxtaposed with the ugliness of disease itself and socioeconomic ills. Yes, of course, it affects predominantly people of Black heritage, but I hope I have managed to convince you that the story of sickle cell disease is also full of nuances and complexities that go beyond this. It reveals a unique discourse and history encompassing victories, failures, and deeper persisting struggles that belongs to us as a collective humanity. There is still lots of work to learn from and improve in order to transcend these constraints and bring about effective solution for diseases, thereby alleviating the shared burden of human suffering. We continue to strive for this brighter horizon. Thank you very much, everyone, for listening to this webinar. So I'll just stop share now.
Puru, I'm happy to start.
Yes,
Okay.
please. Yes, please.
Thank you. I was just waiting. So Norris, thank you so much for that presentation.
Thank you, Prof.
It was fantastic.
Thank you.
Over many years, I've interviewed students from medical school and often hear them say that their childhood experience of somebody with a disease or in their community inspired them to do medicine. And then I often sit and wonder whether that actually comes true. And you're one of it may often come true, but you're certainly an example of where that has come true. And it gives you a real authenticity in talking about this, which is absolutely fantastic. And that I love a talk that starts with the personal perspective, a historical perspective, has some sociology, has a good helping of genetics, and finishes with some health economics and aspirations for the future. So a really comprehensive presentation, which I think will have appealed to all the audience and all the people that you identified as being present in the audience. It makes you an inspirational example of what medicine can do for the good. And it also gives me great joy that part of that was forged here in Brighton. So congratulations and thank you. There are a number of questions in the Q&A, so I'm just going to make perhaps an observation that I think I've already lived through 3 false dawns for genetic therapies, but you feel that is where the answer may lie, or?
Yeah, so I think, yes, the gene editing is certainly, so I mean, if like Apple technology is the start of a new sort of paradigm in terms of the technology that we can use, and I think it will it is curing patients with sickle cell disease. So it has answered the fundamental biological pathology of that, but obviously the issue that many of us didn't realize was how do you translate that to the bulk of the disease, which is in Africa, with cost implications. So clearly that's will need much more work, collaboration between pharmaceutical companies and universities, as well as political governments in Africa to try and sort of allow for things like that. So there's a lot more complex, nuanced type of planning. So that goes beyond just the science itself. So that's one of the downsides, I would say. But I think it's gene editing for many diseases, including even hemophilia, has taken a good trajectory. So, but it's just in the case of sickle cell disease has more sort of nuanced structures to navigate.
Okay, well, let's hope. So I'll hand over to Puru to manage the Q&A session, because I can see you've already got 14 questions to answer.
Firstly, my genuine thanks as well from myself and obviously on behalf of the OHP committee for that simply wonderful
Thank you.
presentation on a really, really important area. And I think we'll dive straight into the Q&A. If I may, I'm just going to highlight a couple of people. So I'm going to say Nisal, Nagin, Freya, Dr. Tim Chevassut, Fernando Wilson. If you are happy to ask your question live, can you just post that into the chat column, not the Q&A, the chat, and I will promote you to a panelist so you can ask that directly to Dr. Igbineweka, because I think it'd be just wonderful to see some direct interaction between the audience and the speaker. We'll go straight into an anonymous question, which asks, at what instance is bone marrow transplantation required, as this seemed to be the only cure for sickle cell disease?
Yeah, so it's a good question. So there are stringent indications for bone marrow transplants, and we would only do it because of the severity, the complications that you could get from a bone marrow transplant. So we restrict it to very severe individuals. One of those indications is obviously having recurrent strokes or a very severe sickle cell disease that is not being controlled with hydroxycarbamide or blood transfusions. So under those type of circumstances, would you sort of enlist or someone for a transplant? And then even then you would need to make sure that you've got the patient's match. If they've got a match sibling, you have to take that into circumstance, because what you've got to balance is that their pre-existing life with sickle cell disease prior to transplant, would it be better than when they did have the transplant? If they did have the transplant, you would hope that the transplant would make their life slightly better than pre-existing. If it's not, then you wouldn't embark on the transplant route.
Fantastic. I think we have Dr. Chevassut as a panelist now. If you're happy to ask your question live, please do unmute and go ahead.
Great. Hi, Norris. That was absolutely fantastic.
Thank you.
It's great to see you, albeit over the computer monitor. You know, you're someone who I've had the great pleasure of working with. Well, you know, as a trainee, academic foundation trainee, going back some years, and then as an academic clinical fellow. And then, of course, you went on to do the Fulbright Award in America, which is a remarkable sort of feat in itself, a tremendous achievement to get that. So, you know, just a few words from me, you know, just comments on your career to date. I've got absolutely no doubt that you're going to go on to great things in the future. And I think your talk was very much, you know, evidence of that. It was the most inspiring talk I think I've heard on sickle cell disease in very many years. And you know, as you know, I was wondering halfway through your talk whether I should turn around all my research and focus on sickle cell disease.
Yeah, definitely.
I have dabbled in it over the years, in large part when you were working with me just a few years back. There are many questions I could ask. I might, if I'm allowed, just ask two brief ones. I arrived a few minutes late, but I suspect you haven't covered this already, and that's obviously a question to do with COVID and whether patients with sickle cell disease are at increased risk of from the COVID coronavirus. Maybe do you want to ask that one first of all?
Yeah. So the studies, I think one was led by Professor Mark Layton at Imperial. He was coordinating the studies of sickle cell disease and COVID, and what they deduced and concluded was that they were at increased risk of COVID infections, but quite luckily the mortality rate wasn't significantly increased compared to, say, the general population. We don't know the reason why that was, but it's been investigated. But certainly they are increased risk of infection, definitely.
Okay, that's interesting. That's good news, I'm sure. And the other question, really, of all the remarkable advances that there have been in sickle cell disease that you describe, and the hopes for better treatments in the future, if you were to predict, for 10 years' time, when many of the students listening might be hopefully training in haematology themselves, what one treatment do you think will we be using then that will enhance the lives and prognoses for sickle patients in 10 years' time?
Yeah, so it's a good question, Tim. I think definitely, I think stem cell transplant will be here to stay. It was been here for about sort of 20 years, but the people who are specialists in transplants have been working very, very hard to make sure that it's the tolerability of it in terms of reducing the complications in sickle are met, and so they increasingly sort of pushing that boundary. So I think stem cell transplant is one to definitely be conversed with, and I think even the gene editing itself is through a stem cell transplant approach, except the only difference is that we don't use donor cells like we would do in stem cell transplant. We would use the patient's own edited cells. So knowing about transplants would be helpful. Gene editing obviously would definitely become more refined, and we'll know a lot more about it. And I think also we will have a lot more disease modifying agents, and even with Voxelotor, I think the way it's been more targeted at the pathogenesis of sickle, I think that was a quite clever drug. My only reservations about that is that it sort of causes the affinity, oxygen affinity curve to shift back to the left. So I often have concerns that naturally sickle patients are at the right so that they can deliver oxygen more readily. So shifting to the left, would that have some problems? But so far, I think we haven't seen.
Thanks, Norris. And just finally, I just hope that in 10 years' time, once you've finished your PhD and published many successful papers and training, that we might be able to tempt you back to Brighton. I'd love to work with you again.
Oh, thanks. And I want to say, Tim, you have been an excellent supervisor, mentor, everything. I mean, a role model to follow. So thank you so much.
We have the Sickle Cell Symposium coming up in January. I hope I can call upon your input
of course
once again.
As always.
Thanks again.
Thank you.
Fantastic.
Thank you.
That was simply brilliant. It's basically two of my heroes in terms of hematology from BSMS coming together. That was just fantastic.
Thanks, Puru. Thanks very much. Very kind, and well done for organising a great talk.
Indeed.
Good luck with your group as well.
If I can, Norris, sorry, if it's possible for me to just bring in my opposite counterpart from BSMS ACS Society, because I think Ola would like to make a comment.
Of course.
Sort of not part of the Q&A, but Ola, if you can, I think you should be able to unmute yourself and go ahead.
Hello, hi. My name is Ola. I'm a third-year medical student. I'm the current president for BSMS ACS, and having listened to the talk, I've been really inspired, and I just thought I had to take the opportunity to, on behalf of BSMS ACS, thank you for taking the time out to present this webinar. You're certainly a role model for us, and this talk really hit home because I grew up in Nigeria as well, and I saw people that had sickle cell and the stigma behind it. But yeah, as I said, you're a role model, and you've inspired me, and I'm sure other people that have listened, and I hope to someday be able to carry the torch and continue to advocate for Black people and other ethnic minorities to get rid of as much as possible the inequalities in healthcare. So thank you very much.
Oh, thank you. It's a delight. Thank you so much, Ola. I really appreciate that. It's an honor and delight to speak to you today. I'm glad I'm glad that you've learned and felt inspired. So I'm really honored. Thank you, Ola.
Thank you. Thank you.
Thank you, Ola. I think we'll go back to the Q&A, which is another anonymous question. And that is, if all precautions are adhered to, such as regular checkups and the use of penicillin and related drugs for sickle cell disease patients, in what way does this drastically reduce the mortality rate?
Yeah, it's a good question. There aren't sort of any studies that actually quantify how much risk has been reduced, but we do know that when the prophylactic penicillin was introduced and when multidisciplinary clinics were introduced, they did lead to an increase in the life expectancy of patients. What the actual quantity is, we don't know. But even if when patients sort of adhere to this regimen, sickle cell is a very unpredictable disease. Complications still happen. Us hematologists, we're very aware of that. And so, yes, of course, having them in clinic, monitoring in clinic and getting them on all the right medications is one thing, but the complications can still arise, although less than if they weren't on these sort of interventions.
Fantastic. We'll move on to my colleague, who is the other OHP co-president, Nagin. She asks, when you were still a medical student, did you know you wanted to go into hematology?
Yeah, so when I was a medical student, I've got some colleagues here. I'm sure that I've tuned in. They were with me in medical school as well. I think I knew that I wanted to understand more about sickle cell disease. I wanted to, yes, I did. I think as a medical student, I think I did like blood, and I liked blood. The reason why, not because it sounds wrong, but I liked blood because it had a scientific basis to it, so you could dissect it very easily, and it's got a very nice scientific underpinning with cellular organization, genetics. I knew I wanted to go into a specialty that would involve that, and so obviously hematology was a natural sort of preference. I did and R between hematology and medical genetics, but it was hematology for me eventually.
Fantastic. If I may be so cheeky in asking a question of my own, which relates to the biopsychosocial aspect, which you covered towards the latter part of your presentation. I think just reflecting on what I saw in secondary school, one of my fellow colleagues was he suffered from sickle cell disease, and the sheer amount of resilience he had to have to endure various issues during his education was really sort of emotive for me and my fellow colleagues in the year. So I think my question for you is, as a clinician, especially dealing with young children, thanks to all the screening procedures we have, which sort of identifies the disease when patients are quite young, do you think the budding hematologists out there need to go beyond sort of the clinical confines and actually provide that compassion, support to help these young people during very difficult phases of their early lives?
Yeah.
Because they can't lead normal lives like other kids. And do you think it goes beyond the confines of clinical practice, whereby you're just seeing patients within clinics or the ward? Being something more of a friend almost.
Yeah, it is a good point, and it's well known that sickle cell disease goes beyond just the clinical domains. It does involve the psychological and social. In most sickle cell centers or big hematology departments that have sickle cell centers, most will have access to a sickle cell nurse. Most will have access to a psychologist, sickle cell psychologist. There's a designated psychologist. Most would have access to a sickle cell social carer or social worker. And what tends to happen is that the consultant ward round on two times in a week, there will have these psychologists and social worker present on the ward round to help to address these needs, because obviously there are complex issues that go beyond just treating the pain, and so that's why. And I've seen this model applied here in the London in the UK, and this model is also applied in sickle cell centers in the US as well. So and rightly so.
Fantastic. If I may allow our Director of Haematology, Nasal, to come on and ask his question live. Nasal, you should be able to unmute yourself and pose your question directly to Dr. Igbineweka. Nasal, if you're talking, I think you're muted.
Can you hear me now?
Yes, go ahead.
Can you see me on the video? Hold on. Oh, come on. Come on. Hey, how are you?
Hello, Nisa.
Hey, thank you so much for your presentation. It was really, really good and really insightful. So thank you so much for your time.
Thank you very much.
I have a couple of questions. And first of all, you mentioned like people with sickle cell traits. Do they normally go undiagnosed?
So sickle cell traits, yeah, normally you wouldn't really diagnose sickle cell traits, because by and large with sickle cell traits, you technically don't have symptoms most of, and so it's treated as a benign form. But those of us who understand the disease are aware that obviously if you strain people with sickle cell traits, for example, if you put them in high altitudes or you get them to do exertional related things, then you are obviously increasing the chance of more sickle cell polymers being formed and more complications from that. But it's obviously very rare. There is also increased risk of rhabdomyolysis in sickle cell traits as well, a very small risk. And there's also a very small risk of renal medullary carcinoma in sickle cell traits. But apart from that, it's considered as a benign condition with those caveats. I think anybody with sickle cell trait is always just important to say that, yes, it's benign, but here are some of the risks. And also its important implications for you in terms of if you want to have children in the future, in terms of partner testing, that is very important.
And you mentioned one of the celebrities was an NFL player.
Yeah.
And so how does he manage with some of the symptoms of?
Yeah, it's because especially in the past, the doctors would always say to patients with sickle cell disease, don't avoid sports and don't try and exert yourself. Yeah. In his case, he was an NFL player, and he was able to manage. Remember, not all sickle cell patients are the same. If we tested his blood, he may have high levels of fetal hemoglobin, which allow him to maybe not be as affected as maybe somebody with severe sort of HBSS sickle cell disease as well. Okay.
And you also mentioned that there's some stigma and secrecy surrounding sickle cell in the BAME society community, or in Africa especially. Like, why is that?
Sorry, could you repeat the question?
So you mentioned that there was some secrecy and stigma surrounding the sickle cell disease.
Oh yes, yeah. So because of some of the cultural implications, for example, if you had a child, so for example, some West African cultures saw sickle cell disease as a bad spirit that will come and torment the family. So therefore, historically, there's been that stigma over thousands of years that you don't want to have a child with sickle cell disease because all they're going to give to you is grief. Okay. And then also for the sickle patients themselves or the sickle individuals, I mean, if you're constantly missing school for some certain reasons, and you're probably in some areas, you're probably one of the few Black people in school, and then you've got a condition that makes you miss school. You may not want to talk about it, and so there's many complex factors around that. Yeah.
Okay, thank you so much. That's all.
It's a pleasure.
Thank you very much. Thank you very much, Nicole. Our next question is from a council member of Brighton and Sussex Medkey. So it's brilliant to see Freya here tonight. Her question is, how would higher levels of maternal fetal hemoglobin, so 20 to 30% pancellular, affect fetal development?
So I'm taking that question is more of how will the fetal increased levels of fetal hemoglobin above 20% in all cells stop? Yeah, so essentially it's just the physical component that if there's more fetal hemoglobin in the red blood cells, then there's less of the sickle cells polymer formation. So the fetal hemoglobin is a direct inhibitory effect to the HbS polymers. So that's why you get less sickling.
Fantastic. Our next question is from Fernanda Widdowson, who is a member of the OHP committee, and that is, do you think physicians diagnose sickle cell disease too quickly in Black populations and too quickly discount it in white populations due to stereotypes of patient demographics?
Yeah, that's an excellent question, actually. So in the UK, we have, so there's newborn screening, which I said has worked very well. And there's two types of screening. There's universal screening, which you just screen everybody for sickle cell at newborn. Or there's screening where you target high-risk populations. And studies have shown more recently that actually universal screening, even though you have to screen the whole population, works out to be more cost effective, because you can see why. Because obviously if you pick up the sickle mutation very early, you can manage things much more early. And as I said before, the mutation is moving into groups we wouldn't traditionally have ascribed to as having been high risk of sickle cell disease. So that universal screening is much preferred.
Fantastic. A question which related to the gene therapy portion of your talk. I was just looking at a couple of papers, especially from 2013, when nanomedicine seemed to be the future, and that sort of died down a little bit. I don't know from the research which you've been doing, especially into sickle cell disease, things like zinc finger nucleases and tau effector nucleases, which back in 2013 seemed to look like the future. Do you think nanomedicine has a role to play in sort of trying to find the holy grail of cures to cure sickle cell disease? Yeah,
it may have a role. Nanomedicine is a big area, so it could have. I won't exclude that. Yeah, but what tends to happen is that sometimes a lot of these exciting findings in the lab, by the time you get them to sort of phase 1, phase 2 clinical trials, they turn out to be insufficient or limited data. So that's why, yeah. But yeah, gene therapy is looking very promising. As I said, it's just we need to refine more things related to it.
Fantastic. I think we'll go with another anonymous attendee, who asks, what was the documented evidence for the first case of sickle cell disease, and how reliable is it? If a disease characterized by the hemoglobin of red blood cells, how can we be sure that it wasn't something symptomatically similar?
Yeah, no, again, it's a good question. It was given as something that was causing pain. Could have been rheumatological, it could have been hematological. They obviously are sort of just extrapolating from the documented evidence that was received, but certainly as you started to get into more the West African concepts of sickling, they specifically related to children with sickle cell who always died and who always had pain. So that sort of restricts the kind of syndromes as such. But obviously, we were not in the era of molecular diagnosis back then, obviously. So we can only make inferences from the stories, but obviously we can't be 100% accurate that this is so all of that is just inferences. Yes. Fantastic.
If we go to another question from an anonymous attendee, it's almost a clinical question. So if you are looking after a patient at 3 a.m. in crisis, what is the best thing I can do for them until I can get a hematologist involved in treatment?
Yeah, so obviously oxygen, you will get trained into sort of emergency management, but always make sure airway is cleared and make sure oxygen, so because sickle cell patients, you want to check their oxygenation. They tend to drop their SATs quite rapidly for various reasons. As I said, they're increased risk of clots, so they can have a pulmonary embolus, or they can have acute chest syndrome, which is represented by hypoxia and new infiltrates on the chest X-ray, as well as a temperature spike, but not always. And so they can drop their oxygen levels quite quickly. So you want to make sure that they're on oxygen as well. Check their blood pressure as you would for circulation, and then maybe give some IV fluids. Most patients with sickle do have IV fluids, but you don't want to overload them. It's just to keep the blood less viscous. As you know, their blood is quite thick, so you want to kind of keep them hydrated. And then you want to give them pain relief, and then you take some blood tests and then make sure that the hemoglobin, so you want to check the hemoglobin, make sure that it's not too low. And if it is too low, because sometimes obviously anemia can be the cause of their crisis, then you want to see if you want to transfuse them. But as I said in the presentation, these patients should all have sickle cell care plans, and they will tell you what to do now for the initial investigation, initial sort of management of the patient, what painkillers to give, whether to give IV fluids, whether to give blood, or whether they've got antibodies, things like that. So it's now become, so if you're an A&E doctor, you'll be able to access that very readily of what to do with the patient. In the worst case scenario, if you don't know, or there's no sickle cell plan, there's always a hematologist 24 hours a day, and we don't mind being called. That's the reason why we're there. So we don't actually mind being called if things are not going the way they should. We rather be called early than later, actually.
Dr. Igbineweka, I think we lost you for the tail end of that.
Okay. Yeah, I can hear you.
Yeah, if you wouldn't mind just repeating the last couple of sentences you said, which I think may have been missed.
Yeah, no, I was just emphasizing the fact that we don't mind being called overnight. If a patient is sick, then you need to speak to get urgent advice, definitely. So we rather know earlier than later, because as I said, they can deteriorate very rapidly. So it's good to get expert advice very quickly earlier on.
Okay, thank you so much. I'm going to have to ask if in what direction you'd like to go from this point, because I know we've already eaten up plenty of your evening. You've answered 16 questions, which has to be a record. And we've still got questions coming in. So we've got 7 questions in here. I'll leave it entirely up to you if you want to carry on, or I can email these. Oh, we've gone up to 8 now. But if you want me to email these to you later, and then you can pen down an answer.
Yeah, that's fine. What time are we making it now? Is it 8 o'clock now?
Yeah, we've got 9 minutes till 8, and I think we still have those Anthony Nolan reps to.
Yeah. So maybe we can call it an evening and then email the questions to me then.
Yes, I will certainly do that. We have 8 questions, so I think it's just a pure testament to your brilliant talk, but also the fact that people really want to engage with you, which is fantastic to see.
Thank you so much I want to say thank you to you guys for inviting me to speak, and it's an honor to speak today, and thank you. I'm glad that you guys were inspired from the talk that I did before with Dr. Chevassut. So thank you, and keep up the excellent work with your studies and things like that. So yeah, great.
No, thank you so much. It's I think it's difficult to convey one's genuine thanks in this virtual world. I feel the need to give you a hearty handshake and actually present you with something from OHP, because frankly, this has been a superb event. You are a passionate educator and a brilliant academic, and I think sort of that shouldn't come across as flattery in any way. It has truly been a fantastic evening, and I think the rest of the audience and my committee will agree. We hope that your connection to Brighton will continue.
Yeah, definitely.
with the merger of the trust, future leaders like yourself, I'm sure are required, especially if the chief executive position comes up open, and if you've had enough of clinical medicine, I'm sure that will beckon for you at one point. But yes, thank you so much.
Thank you, Puru.
So if we can move on to Ellie Brooks, I think if I bring you on as a panelist for your section.
Hello.
Hi, yeah, we can hear you, so please do go ahead.
Hi, so I'm Ellie Brooks. I think Valentina was supposed to be here as well. Is she not coming up?
I cannot see her on the attendees, so...
Oh, I can see her.
Oh, right, yes. Okay.
Sorry, she might have just joined. Sorry.
Yep, so both of you should be able to, if you unmute your microphones.
So we're both from Sussex Marrow Society that both Sussex students and BSMS students can join. It's volunteer, so if you're interested in what we have to say, please get in contact with us.
Yeah. So I'm Val. I'm the donor recruitment coordinator. And
I'm Ellie, and I'm the co-president.
And we're here to tell you that every 14 minutes, someone is diagnosed with blood cancer in the UK. And for many of them, a transplant will be the only chance to live. 25% of patients usually find a match within their families and relatives. But then, of course, for the other 75%, that's where Anthony Nolan comes in place. So Anthony Nolan is a charity that has a worldwide stem cell register and has now saved 19,000 people since it was established in 1975. So Marrow is the student section, let's say a student group that recruits people and sign them up to the stem cell register. And we also help them by raising money, because of course the whole process is quite costly, as most of you medical students might know. Because, for example, to sign a person up, it's about £40. So clearly the charity cannot just run itself somehow. And also Marrow recruits 1 in 4 donors on the Anthony Nolan stem cell register.
So I'm going to tell you a little bit about what criteria you need to fill to be able to sign up to the stem cell register if you're interested, and then if you are on the stem cell register and end up being the perfect match for somebody to be their donor, what process you'd have to go through. So to sign up to Anthony Nolan stem cell register, you have to be aged between 16 to 30. This is just because that tends to be the best age range for people in good health, and that's where they get their best donors from. But although you can only sign up until the age of 30, you'll stay on the register until your 61st birthday. So from any time from when you sign up until your 61st birthday, you could potentially be called on to donate your stem cells. So at the moment, we normally recruit people in person, but at the moment we're very much relying on online recruitment. So what you'd have to do is go to a link which is antinolan.org/Sussex Marrow, and fill out a quick form, and you'll just need to detail some basic information about yourself, your general health. As long as you haven't got any quite severe conditions, you should be able to sign up as a donor. And then some sort of kits will be sent to your house a few weeks later. And with them sort of kits, you just need to do a 30-second swab of each cheek and put them back in the envelope and send them back to Anti Nolan, and they will notify you once you've joined the register. So the two ways people donate, if they are chosen, you're only chosen if you are the perfect match for somebody that has blood cancer and needs that stem cell donation to survive. So the two ways are, one is a peripheral blood stem cell collection. So it's quite similar to giving blood. A few days before you give your donation, you'll go to your local doctor's surgery, and they will give you some injections to promote stem cell production within your blood. And then after a few days have passed, you'll go to a collection centre. There's one in London and a few other cities across the UK. The closest one to here is London. And you'll be hooked up to a machine for about 4 or 6 hours. You'll have a needle coming out of one arm, and it will go through a machine, filter out your stem cells, and then they'll return blood back to your other arm. So 90% of people that donate will donate by this method. But unfortunately, because some blood cancer patients are so ill, 10% of the time a donor will need to donate by a bone marrow transplant, because that gives that individual the best chance of survival and of having a successful transplant. So it's quite a short procedure, and you're under general anaesthetic the whole time when you donate bone marrow. And you'll feel a bit achy for a few days afterwards, but the pain is nothing compared to the fact that you're giving somebody else another chance at life. At the moment, we are trying to encourage people from more diverse backgrounds to sign up to a stem cell register, because currently, if you are from a white European background and you are looking for a non-related donor, you have a 69% chance of finding that individual on the stem cell register, whereas this drops dramatically for somebody from a Black, Asian or minority ethnic background to only about 20% of finding an unrelated donor. So I'd massively encourage anybody from a non-white European background to sign up to the stem cell register, because it's urgently needed. If you are unable to donate, we obviously fundraise as a society. So if you're interested in getting involved, we're actually holding a Halloween competition right now. You can check it out all on our social media. It's just Brighton and Sussex Marrow, pretty much everywhere. You can carve a pumpkin or show us your best Halloween makeup look. So I think Val's put in the chat the link to sign up to a stem cell register if you're interested. There's more okay, no, I think it's in the chat now. If you are interested in signing up to the stem cell register, it's an amazing thing to do. Thank you for having us.
Yeah, thank you.
No problem at all. Thank you very much, Ellie and Valentina, for coming to our event and speaking, obviously, at the end. I think I will just close, because we have finished bang on time pretty much for our extended time slot for this event. And I will just close by thanking Dr. Igbineweka one more time, because it's simply fantastic. A real honor for you to have come and spoken to us. The remaining participants, please do fill out the survey, which will be sent out at the end of this event, in order to obtain your certificate, which you can then post on your HSE portfolio or for various other things. So I think we'll wrap it up there. Just a notice in terms of the OHP Book Club, which is sort of our weekly event every single Tuesday, looking at being morsel. We'll be looking at the next 2 chapters within that series tomorrow night, if you hadn't had your fill of OHP this evening. But yes, thank you so much for all of you who've remained, and we do hope to see you at our next event. Huge thanks again, and I can see Dr. Chevassut typing away in the chat box. I echo every single word coming out from there. Simply fantastic. Thank you so much, Dr. Igbineweka, and we hope to see you again back here at OHP, if not Brighton. But yes, have a good evening, everyone, and please do stay safe in the meantime.